Right, we'll get cracking. Apologies from Steve. Steve is still not well, and unfortunately, we hope he'll be back early in January. Michael Meyer is on his way. He's delayed in traffic. And I'd like to introduce Sandy Jones, who's sitting on David's right, who's joining us as our new company secretary. In fact, you have joined us, haven't you, as of 3 days ago, I think. So welcome, Sandy. The minutes that David Hogarth, you got an issue on the minutes, haven't you? Do you just want to?
Yeah, thank you very much.
Why not just use his thing, her mic?
It's about section 35 of the minutes, which I think completely misrepresents really what I was trying to say when you were kind enough to allow me to come up and talk. I was trying to make the point that the guidance for the public was very discouraging to members. That doesn't seem to have come through. And I wasn't saying that bringing concerns to the CQC was a substitute for surveillance, that people should not do surveillance, but should bring. What I was actually saying was that surveillance was necessary often before you bring things to the CQC in order to get the evidence. And I was hoping the document would reflect that. Those, I think, are the main points, and I rather hope that the next lot of minutes would actually put those points in rather than just saying David Hogarth wanted it tweaked.
Yeah, no, we'll correct that. I remember exactly what you said now that you've reminded me, so we'll change them. So thank you for that.
Mr. Chairman, could I also say paragraph 9? I'm never quite sure what I say, but I'm pretty certain I didn't say it had stuck me. It should be struck, I think, rather than stuck.
Yeah. We can make that change.
One thing that I forgot, section 45, it's not me that said it's Mr. Pike. Hogarth should be struck out and Pike should be.
Okay. Yeah. All right. Right, thank you, David. Excellent. Right. I think there's 2 matters arising, but they're both picked up. So we'll move straight on into your report, please, David.
Thank you, David. Good morning, everybody. This is largely an updating report to colleagues, and I'll clump some items together in introducing it. So, providing a verbal update on resources and the work programme, and linking that to paragraph 2, the update on recruitment. If you've added the 2 columns in the table under paragraph 2, you'll see that what we're looking to do is, by the end of next year, is recruit 1,411 inspectors to our establishment. The second column is showing that we've currently got 852 inspectors, and that the difference between those is 559, if my arithmetic is up to it. And that's the ask, the recruitment ask, that we are making across the organisation. I'll provide some updates on numbers in the minutes. So the first paragraph, the balance between the work programme and resources, is really what the senior team and managers throughout the organisation have been occupied by, how we can balance the commitments that we've made about inspections with the people that we've got available to undertake that work. We've completed just over 13,000 inspections during this current year. We've prioritised acute hospital inspections and those inspections where we feel there is greatest risk. But we'll begin the next financial year with something like 65% of the capacity of inspectors that we plan to have. So what we're trying to do is balance the people that we've got with the work that we've got. In terms of supporting staff to undertake the work that we've got. Recruiting additional staff is key to this, but then looking at how we can improve and ease some of the processes and systems that we've got in place, particularly processes and systems around quality assurance, etc. And we're also offering time off in lieu and being clear about that, and overtime payments for those that want it. That doesn't necessarily ease the pressure on people, but it is a recognition of what we're attempting to do. So that's all I wanted to say on the recruitment and workload issues. The pipeline in terms of appointments, an awful lot of work has been undertaken by HR, and there is good progress being made. So on hospitals, we've got 116 candidates booked in for assessment. Some of that will start before Christmas and the majority in the new year. We've offered 26 posts so far, and that's roughly working out about a conversion rate of 1 to 3.5 applicants. So for every 3.5 applicants, that's converting for 1 appointment. On mental health, the secondment scheme and the targeted recruitment campaign has resulted in 159 applications, and 121 of those awaiting shortlisting, with 58 candidates booked into assessment centres which begin in January. In adult social care, there was a very targeted campaign that ran during November and the beginning of this month, and we got 583 applications, which was more than anticipated, and so far 72 have been shortlisted, and they'll go through to assessment centres in the new year. Registration is also an area where we're looking to recruit, and a targeted campaign produced 129 applications, and 22 candidates have been shortlisted and will go through to assessment centres in January. And on PMS, we had 126 applications, of which 23 are so far shortlisted, with another 92 candidates going through that shortlisting period, and they'll go through 2 interviews again in the first 2 weeks of January. And then on children's services inspections, 85 applications received. There's a further 60 going to be shortlisted over this next couple of weeks. And 9 candidates have so far been processed through. So effectively, those campaigns have generated a lot of interest, and the conversion rate is moving through. But the bulk of that activity and final results won't be known until probably the end of January, in fairness. We've got new arrangements for partners for recruitment, which we want to put in place from January of next year, which will help us make progress in relation to the recruitment that we need to do during the calendar year 2015. We've conceived that the plan for recruitment needs to be in two phases. The first phase running to April 15, where we're looking to recruit 300 additional staff, inspector staff, and the period from April to December, where we're looking to recruit a further 300. So that's the approach we're taking, and that's the progress bringing us up to date. In addition, there are analysts that we're looking to recruit, and I've not got the figures immediately available for analytical colleagues, but Paul and Emma Rourke are looking to increase the number of analysts that we've got in place. I'll pause there, David. What I was going to go on to do is, and then say that the approach to procuring analytical services in relation to hospitals is also a different way of thinking about how we can ensure we've got the analytical capacity in the organisation. It is something that colleagues on the board have raised previously about looking to contract with other organisations that might provide this service, and what paragraph 3 is doing is just setting out our intention to do that. That will come back to the board in the new year, because we anticipate that contract will be of a value that will need board approval. But if I just pause there on the recruitment.
Paul, sorry, Kate, did you just want to add to that on the recruitment of analysts?
Only that the board had previously signed off structures with around about 300 total in intelligence. We're around 35% short of that. We are also looking then alongside, as David says, the recruitment of analysts, more sort of novel methods of fulfilling the capacity, which includes part 3 of the update.
And the graduate?
On the graduates, yes, we have 13 graduates, I believe it is, joined us about 2 months ago. They do a set of 6-month rotations, and the idea there is where we have found it difficult in the past and continue to find it difficult to recruit analysts in at a more sort of senior level. The more we can grow our own, the more we'll be alleviating the pressure for the future.
Yeah, I mean, it's on the recruitment of inspectors, and I know we've identified how many inspectors we need, and you know, I've no reason to doubt that's not right. But I was wondered if we'd sort of given consideration to certain aspects of the sort of inspection process being, I don't know, tendered or given to particular organisations, or you know, do we actually need all those inspectors? You know, is there a different way of doing it, or do we need inspectors to do that? Do you see what I mean? Because obviously you need an inspector to have the sort of regulatory skills, which is very unique to the inspectors. But there are other things that perhaps potentially could be done if we thought about, you know, procurement or something like that. You know, so a different way of maybe doing it instead of recruiting lots and lots and lots of inspectors.
I think just two things on that, maybe, Kay. One is, of course, we do bring in lots of people who aren't inspectors into our teams to do the inspections. And we did look at outsourcing inspection very much 18 months ago in the way that Ofsted have done it, because Ofsted are now bringing it all in-house because it hasn't worked for them outsourcing it. And so we came to the view that outsourcing it probably wasn't viable.
I mean, I wasn't particularly suggesting that, but it was sort of to take some of the pressure off, you know, gathering information or, you know, meeting with service users, stakeholders, that kind of thing.
So just on this, David, so there is a conversation going on across the exec team with colleagues about can we think of the skill mix for inspection teams? So a couple of things. In the open door sessions I've been having with staff, one of the questions I've been asking is if your team is of 8 people, is a trade-off here, instead of having 7 inspectors, having 7 inspectors plus some business support people. So there's a whole bunch of process work that can be taken away. And I think there is some appetite for that, and I think we'll try that skill mix. Mike and Paul Elliott have been talking about something along the lines of an assistant inspector, an associate inspector, and we're going to trial that concept. So thinking differently about what the skill mix is. So rather than parcel up bits of the process, which is already pretty complicated, and outsourcing bits of it, thinking about whether we can have different skills to support the delivery of the inspection process, which will help us, and we'll trial those as part of the changes. So it's not just that we're trying to recruit more staff, we're trying to think differently about what the skill mix is. And I think the analytical one is a case in point where we think there might be some mileage in actually looking at externalising some of the work. And let's test the market and see.
Yeah, I mean, that was more kind of in line with what I was suggesting rather than sort of mass outsourcing. But that's good, thank you.
Thanks. The mental health recruitment is obviously a concern, but it's slightly curious that looking at the table that our recruitment in social care is so much better than it is elsewhere. In other words, just by a quick calculation, we've got something like 80% in social care in post compared to about 20% in mental health. Is there something that's a very big difference, and it suggests a difference in the process or the incentive or something which maybe we could learn from across that?
I think the difference is inspection has been going on for a while in social care, and people see it as a part of a career pattern, and they're just learning that in other areas. And so if you're in education or if you're in social care, you have seen since the 1980s the possibility that at some stage you might become an inspector. And I just don't think we've got that with the other professions yet.
And I think there's also a couple of other local factors to take into consideration. First, that when we did the preference exercise at the beginning of this financial year, there was people were asked to make the distinction between hospitals, social care and primary medical services. And there were some people who actually might have wanted to go into mental health, but didn't know at that stage that there was going to be a separate team in mental health within hospitals, so came into adult social care. And certainly some of those are now identifying a preference to move into the mental health teams rather than stay with adult social care. So there will be some shifting around of that. And secondly, I think that the preference exercise, the pre-existing workforce, we had a lot of people who had skills and experience and expertise, and it may well absolutely reflect what Paul's just said, who were appropriate to move into adult social care as opposed to into some of the newer areas. And I think that the final point is that although we've struggled to get the numbers that we need as well, and we still do need those numbers, I think have had more positive response from the sector in terms of people wanting to come in to CQC to do that. So, I think I'd say probably the specialism now of a mental health team sitting within Mike's directorate is probably the lesson learned that actually will make things better for you in the future.
Lewis, you're absolutely right that the gap is the greatest in both acute hospitals and in mental health. We are very well aware of it, which is why we've been doing these targeted approaches, particularly looking at the secondment route of getting people from NHS to come in for a year or two, which we believe will be good for CQC, but actually also good for healthcare in the long term, because people will have got the experience of looking at quality and assessing quality across the health service in that time. And that is being more successful. And some of the figures that David gave earlier about the numbers coming through now reflect that. So I think we have had a slower start on that, largely because of the preference exercise, and I think we were completely right to say people could go with their first preference. But now we are building up as rapidly as we can, and also just building on what Kay was asking about, the idea of these assistant inspectors, which we will trial, and we should be going out for advertisement on that earlier in the new year.
The only other thing I'd add to the three comments that have been made is that I think the experience of inspecting for inspectors is different in adult social care, is different in primary medical services, and different in acute and mental health. So I think in part, I think Paul's point is there's a longer history and tradition in adult social care, and that will include many staff who used to work for the nursing registration units that were run by health authorities a decade, 12 years ago. So I don't think these are all people from an adult social care background. They happen to be in adult social care because the history and tradition of inspecting nursing care and care homes is longer, I think this is Paul's point, than primary medical services and hospitals. But if you're doing an acute hospital inspection, the rhythm of that is there will be a time where you'll be away from home, and you'll be away from home for a week in order to do that inspection. And there'll be similar arrangements in relation to mental health services. Some of the big mental health trusts, as you know, Lewis, have probably got over 500 sites. So the experience of getting around 500 sites to arrive at a judgment about one trust is very different than you're actually going to inspect even the very largest care homes at 180 beds. Which can be done probably over 2 days, but don't need somebody to be away from home and overnight. So I think there's a different rhythm and a different experience for staff that comes from this. So I think bespoke campaigns which are recruiting people to do a specific job, to do mental health inspections, to do acute inspections, etc., is really where I think we're seeing now the benefit of these numbers coming through, of people expressing an interest and then presenting themselves for interview. So paragraph 4 begins with the progress the Academy is making in terms of the offer. As the board are aware, this is a new concept which has been developing alongside the development of our new methodologies, and its purpose at its very simplest is to ensure that our staff have the capability to do the job that we're asking them to do. The focus has been on training people in the new methodologies, And what this paragraph is doing is reporting on the progress that is being made to ensure those staff who are now operating in the NHS Directorate, the duty of candour and the fit and proper person test, have access to the development courses that are now being offered through the new learning management system. This is now beginning to get the traction, and we've shared with you some of the figures as this approach is going to begin to bear the fruit that we intended. I'll pause at that one because I think we go on to do different kind of updates in the rest of the report, David, if anybody wants to come back on any of the issues in the academy. No, okay, I'll press on. Lewis raised at the last meeting about how we could capture some of the stories, if you wish, that sit behind some of the enforcement figures. So what I'm just flagging in this paragraph, David, is that we said we'd take away from that and work out how in the next performance report we can actually capture some of the stories about the impact that some of our action has taken. So not just report in terms of numbers of warning notices or the like, but we can actually bring some examples of cases and the impact. And I think on that point, David, if I hand over to Andrea, and Andrea will just share with you, and Gail Sterling, who's our Head of Inspection in Adult Social Care, has joined us for this item. And Andrea and Gail will just take the board through the work that was done last week in relation to Merrick Park Care Home, which is where we took immediate action. And I think this probably plays to Lewis's point about getting these stories into the meetings, so that we've got a sense not just of the numbers, because this would be one enforcement action in a report, and this just gives us the opportunity to explore some of the issues that were addressed, and indeed some of the dilemmas that come out from taking that immediate action. So.
Thank you very much, and thank you for the opportunity. So this is Merrick Park, a home in Surrey, in Banstead in Surrey. We had concerns raised with us by Surrey County Council towards the end of November. We organised a comprehensive inspection which started on the 28th of November, and we were already worried on the first day that we were in there. We continue to visit the service over the weekend and completed the inspection on the 1st of December, when we raised our very serious concerns with the provider about the state of care, the state of the environment and the health and well-being of the residents in the home. We started our liaison with both the Surrey County Council and Surrey Downs Clinical Commissioning Group, both of whom had residents who they were supporting in the home. And that liaison carried on throughout the week. We had further discussions on the 5th of December, which was the Friday, and agreed to use our urgent powers to effectively cancel the registration of that provider. And we advised our partners that we would be doing that on Tuesday the 9th. And the purpose of doing that was to ensure that there was appropriate arrangements put in place for the residents to move. We conducted further visits over the weekend, as indeed did the Clinical Commissioning Group, to make sure that staffing levels were appropriate and the residents were supported. We served notice on the Tuesday, on the 9th, and all of the residents were moved on that day to accommodation that had been organised by either the council or the Clinical Commissioning Group. There was a problem on the day with transport, which had been organised by the Clinical Commissioning Group, which did unfortunately lead to some residents moving late in the early evening from 7 o'clock till about 8:20. So that's the kind of shortness of the timeline. It really bears no relation to the amount of work that individual inspectors, the legal services and our partners in the Clinical Commissioning Group and the council did. I think that one of the things and one of the reasons why we thought it would be useful to share this enforcement action with you is that taking this urgent action is not something that we do lightly, because we know that there is a real risk to residents if you move them on a kind of very urgent basis, and we would only do that if we felt that it was absolutely essential in respect of the health and well-being of the residents, and also an assessment of our confidence in the provider to address the concerns that they had. So Gail Sterling, who has joined us at the table, is our head of inspection for the area and is the accountable officer, if you like, in making that decision to proceed with that urgent action. So what I've asked Gail to do is to just explain what weighed heavily in her mind at the point that she was making that decision, which I think brings to life some of the issues that we were facing.
Thank you. Yes, it was a shocking story. I was hearing from the inspectors who were out on inspection. To quote, it was the worst some of them had seen for a long time. But in terms of detail, there were some broad themes around a massive shortage of staffing, shortage of nursing staff. The shortage of staffing was having a significant impact on people who use services. They weren't talking to them. People were left sat all day in chairs with no contact other than a drink, maybe mid-morning, and a bite to eat. They were calling for help, but nobody was responding to them. People were in tears talking to the inspectors, talking about nobody listened to them. They didn't get food. Sometimes they didn't get the choices, and if they didn't like what they were getting, they didn't have an alternative. The staff were at the end of their tether, but they were so busy they just didn't have time to do things for people in a kind way. We saw somebody being moved around moved from a chair to a wheelchair and using a hoist, and the lady became extremely agitated. Staff hadn't talked to her, explained anything, and this lady fell to the floor. We've reported that as a safeguarding, but it was just a picture of everything that was going on. The other thing that weighed with me was that people were trapped on the first floor, couldn't get down because the lifts weren't working all the time. People hadn't had baths for a long time because they couldn't get down to the bathrooms. The water in the upstairs rooms was cold. One service user explained he had his 10-minute wipe with a baby wipe each day, but hadn't had a bath in ages. Another one was cold, lying with a blanket over his head to keep warm. But the other worry alongside of this was the attitude of the manager, the provider. There wasn't a registered manager at the service. There was a manager. The provider assured us he would put extra staff in. Now, the provider is a nurse, and we went to check the day he said there would be extra nursing staff. We got there, there was no extra nursing there, but actually we were told that the provider was the nurse who was due to be on that day, but wasn't there. So it was just this lack of response to everything. And actually we told him everything we found at the end of each day. So even on the first day we gave feedback, but at our meetings with the local authority, they told us that the provider had told them at CQC had said everything was all right. So it was really somebody who was just not listening to what we were saying. We also had concerns about the state of staff because we felt some of them were actually about to go off sick because they were just so stressed, and so you would have a bigger problem. So we took the decision at an MRM that the only thing we could do was to go for an urgent closure. The local authority were fully on board with that, and they had started their provider failure arrangements the week before. So they had already started looking for places for them. So in that respect, that made it slightly easier. We did talk about coming up to Christmas, but we just felt we couldn't leave these people, and we couldn't have inspectors. The inspectors were so worried. They were going in off their own bat over the weekend just to keep an eye on things.
Thank you very much, Gail. Would anyone like to... Camilla, yeah.
Can I just ask two questions? One is, forgive me because I don't know, is this part of a chain or is it a sort of standalone home? And the other question is, do we know how long this could have been going on for? What is CQC's history with this home? Have we issued warning notices? If there wasn't a registered manager, had this flagged before, and if so, how long?
We hadn't had major concerns about this service in the past. I think it was probably that made compliance but actually needed improvement actions under our old methodology. But we hadn't been into them for 11 months as we'd had no alerts to there being any problems with them.
So what did we say about them 11 months ago? That's what I was
they'd met the regulations at that time, they were compliant with the outcomes at that time, but that there were improvements required.
If I can say, Camilla, this is in terms of responding to your first question, this is a provider that's got 3 homes. We have taken this action with the home in Surrey. There are 2 homes in London. One we have been working with the council, and that's closed as well. And the other one we're keeping under close scrutiny. So there's a kind of coordination of action across the 2 teams that are looking at the various services that this provider has. I think this is one of those services that the old regime of compliance against the regulations did not serve us as well as it could have done. So it was a service that wasn't fantastic, clearly, was kind of, we were identifying concerns with it and it would sort itself out on that particular concern, and then we would be going back in and they'd find something else and then they sort that out. So the last time we went in, we were checking that they were had sorted out the problems that we'd identified previously. They had pulled themselves up to compliance, but they obviously were kind of teetering on the edge. And I think that the critical issue for us here is about us making sure that we're picking up, and this was evidence of our good partnership working, because it was Surrey County Council that kind of came to us and said, we're very worried from a safeguarding point of view. We think that the regulator needs to go in and take action. And it's really important. We cannot be there all the time. Providers have to be taking responsibility for delivering services that are safe, compassionate, effective and high quality. But we need to make sure that we're picking up on the smoke signals when they happen and doing what Gail and her team have done, which is go in, take action and be very, very clear about our expectations.
If the owner sets up shop somewhere else, are we able to know that with our registration process?
Yes, we would.
Well, it's a very interesting case, not least because of the point you've just made about the recurrent non-compliance of a more minor kind, which in the end added up to something more serious. I think that's an important message. Could I just ask, what was the response of the families of the people of the residents, and had they previously been raising concerns with other people?
They hadn't raised concerns with us. But they had been raising concerns with the provider, and the families have told us that. The families, I think, they were fully supportive. They've said publicly that it was a dump. They've been worried about it. They've been trying to complain to the owner, but nothing had been happening. But we hadn't got that information. So, but they had been complaining. And I think now the trauma of moving has happened, I think that the families are much more happy with where their residents are, and certainly the feedback we've had from the local authority who've been round and checked them all is that they've all settled into their new places.
Well, just to follow that in a way, one of the reasons I raised this was because, in a previous meeting, was because this is an opportunity for us to tell other families in similar situations that here is a course of action that you can take and something will happen as a result. And that is, in the end, the key message, I think.
What's the role of the local authority here? If it was so obvious to us, presumably there were local authority funded places there. What were they doing and what's the learning for them?
We're going to have a debriefing meeting with the local authority to look at this case. But my feeling is that they responded to the safeguarding information that was coming to them, and concerns must have been raised with them. But we need to look at that as a community as to where we could learn lessons and perhaps pick up the signals sooner than we're able to.
I just wonder if there's, this may happen already, sort of case study learning for other local authorities?
Yes, I mean, I think that, as Gail says, one of the important things here is to share the understanding of what happened. And we've had various aspects of this before in terms of Orchid View, and where we were working with West Sussex there, and have been doing work subsequently with them around lessons learned. I think that there's something for us around the local relationships that we're building up with local authorities through our inspection teams. So one of the things that we've done in adult social care is to construct the management teams so that they are linking to local authorities, so that we can have good relationship management between us, so that people build up that level of trust and understanding, and they know that when they come and talk to us, we will do what Gail and her team have done, which is respond, take action, and work well with them.
Just two questions. One, whether to what extent, if at all, the fact there wasn't a registered manager was an explanation for what you found. That's the first point. And the second point is right at the other end of the process. Once you decided that this place ought to close, what if any, involvement is there with the families of these poor people before or at the time of the move?
In terms of involvement with the families, the inspectors and the manager were on site over the weekend, and certainly were there on the day talking to families. The local authority took the lead on that because they were organising the placement, so they needed to have those discussions. Again, the feedback I'm getting is there was support for what we were doing, and I think there was an element of relief that something was happening, albeit it went wrong on the afternoon with the transport. But I think fundamentally they were fully involved in our discussions and with the local authority. Sorry, what was your other question?
The question was to what extent the absence of a registered manager was an explanation for what you found?
I don't think it's a full explanation, but I think it's part of it. And we are certainly seeing a pattern where there's no registered manager. It can be very difficult for the quality of the service to be monitored properly, for them to be held accountable for the quality monitoring. In this case, the provider was doing it from a distance and actually wasn't doing anything. And the manager on site was doing some of their own monitoring, but there was no requirement for them to report on issues or pick things up. But so certainly our experience is that where there's no registered manager, there is a drop-off in quality. And that might link why this service has deteriorated in the absence of a manager.
And if I can just pick up the point about the involvement of the families, this is one of the things that I think that we really do need to look at in our debrief with the local authority and the clinical commissioning group, because I think there were lots of us, involved in having those conversations, and some of that I think potentially got very confusing for people, and particularly when things were happening at quite a rush in the last few days, which I think explains some of the concerns that actually meant that at least one of the families took their concerns to the press. So one of the things that I've discussed with the Deputy Chief Inspector Adrian Hughes in this area is, us being having something that makes it absolutely clear what our responsibilities are, what we're doing, what the local authority is doing, what the clinical commissioning group are doing. Here are the numbers, here are the kind of ability to provide that. And if we don't have this at the moment, but I think this experience has really said to me that we need to have something that our inspectors, I mean, they did they did a great. I mean, they were literally in and out there all the time. They were so worried about the people. But if they'd also been able to say, and here's something that you can take and read afterwards in a quiet moment, I think that might have helped a little bit more than just the conversations that we all had.
Thank you. No, it's good to hear a bit more of sort of background and information as to what happened, and I think we ought to sort of congratulate and acknowledge the inspectors for actually pulling out the stops and really taking this seriously and giving it all they've got. So I think that we need to recognise that. There's sort of three things I wanted to say. I mean, even if our previous inspection didn't get fully underneath the issues, nevertheless, this provider, I think, must have changed very considerably. It had gone down quite dramatically in standards. And I think it's just to sort of kind of be aware that that can happen, actually. Things can change very quickly. And so there's kind of no room for complacency. And I think that's particularly the case where you've got maybe residents who are very sort of dependent, say physically, or have dementia. The risk of sort of neglect and abuse just rockets. So I think that that's something that we need to really bear in mind, because things can change very, very quickly. The second point was about the provider, the nurse. Now, we had a question about whether we'd know if this person tried to open up somewhere else, which is good. But I mean, it seems to me that if this person is a nurse, we ought to pursue that. I don't know if they're registered or they used to be, but I think, if they allowed this to happen, this scale, we ought to be looking at that in more detail, shall we say? Okay. And the final point is in a way it's aimed at Michael, because at the last Regulatory Governance and Values Committee, we talked about having, looking at some case studies, and I think this would be quite a good one for the committee to look at in more detail, because we can actually look at what was involved and the resources, the impact, and really kind of get underneath some of the sort of governance that we've got in place for regulation, but actually be able to kind of understand and apply it more, so it to kind of bring it alive and for us to kind of learn as well.
Shall I just come back?
Oh, sorry, Andrew. I was going to say that's an excellent point from Kay, and I think we will definitely adopt this sort of case study approach at the Regulatory Governance Committee. And in fact, Paul also made the point that I think the committee has got rather bogged down in CQC processes and understanding whether the processes are effective, and the risk is that we lose sight of the central issue, which is, are we inspecting, are we looking at providers in a way that stops these kind of problems arising. I actually did look back. There are reports going back, I think, to at least 2009 on this particular home. And even though it was the old regime, there was actually a 35-page report on this home in 2009. I think I may have copied it to David, I can't remember, which was actually a pretty shocking report. I don't think anything happened, or at least it's difficult to see what happened, but it was the same provider. Nothing had changed. And it just occurred to me that when there is a home, or this, in a sense, this probably applies to everything we look at, whether there's a sort of a non-inspection way of monitoring a situation is just quite an intriguing idea. For example, if we take this particular home, or indeed all care homes, if we had, I think I may have mentioned this before, if when a resident is admitted to a home, the CQC was told the resident's name and the relative's name, and hopefully their phone number too. And perhaps the same with staff employed at homes. Would we be able to do, let's say, just as an example, a quarterly telephone survey of a sample of relatives and staff. I don't think this would be a very expensive thing to do. It would obviously be done by Newcastle. You know, they would just become a bit of an outbound calling centre as well as, you know, inbound, which they are at the moment. But this would only apply to homes where colleagues like Gail had a concern that, you know, we might have inspected and it was just about okay, but as Kay was saying, there was clearly a risk of the situation deteriorating. Or, you know, a home like this where there's just been a pattern, a long pattern of problems with the provider. So I just don't know how feasible it is, especially, you know, we've got pressure on costs and pressure on staffing, but some sort of, as I say, telephone survey, you know, may be the way to monitor situations short of doing inspections. I mean, and of course, you know, Lewis has raised before, and Alan Milburn raised it last night. You know, there still is this issue about should there be an app for relatives or indeed patients themselves, if they're able to use it, in which they could communicate easily with their concerns to the CQC.
On the app point, maybe. And
yes, sure. So we will do the app. We agreed in the knowledge and information strategy, I think, that came last board. That was one of the 10 sort of priorities for the strategy, was to launch exactly that. So we'll do the usual on getting the investment case together. It shouldn't be too expensive. Provides opportunities for relatives and carers at any stage. We're also looking through that strategy at whether we can expand our survey programme, not least on the staff side, for adult social care as another means to pick up concerns in individual environments. But we can also look at the outbound calling.
And will you pick up Kay's other point about the nurse?
Yeah. Yeah, and I think that both Kay and Michael are right that what can we do from an intelligent monitoring point of view that assists us, and make sure that we're going back in when we should be. The point about the provider, yes, we will be considering as part of the follow-on action which we would do in any situation, but certainly we'll be doing in this, referring the individual to the Nursing and Midwifery Council.
Good. Gail, it's really kind of you to come today. I know how busy you are, but just while we've got you, it's always dangerous asking a question to which one doesn't know the answer, but I'm going to take a risk on it. I mean, how you find, I mean, just give us a flavour of a day in the life of an inspector in adult social care at the moment.
I think I think that for them it's busy. I suppose that goes without saying. They are enjoying what they're doing. They're enjoying getting out, doing the more in-depth inspections, being able to get underneath what's happening in services. I think there is a worry to them that we've not been into all our services yet, and so there's that worry, you don't know what you don't know. So they're constantly trying to balance checking their inquiries and any safeguarding coming in. So it is about that balancing that risk, about organising priorities for the day and actually dealing with these issues when they arise, being able to stop what you're doing and pick up another piece of work, which is what happened to us all on this particular instance. But I think there's an element of, thank goodness we found it out, thank goodness we were able to make a difference for these people. Sad that it was a trauma for them on the day, but I think a feeling that we couldn't walk away from this service, that we don't feel like that with all of them, but this one we really felt we couldn't walk away from it. And I think they've worked till midnight some nights to get this sorted out, but they feel it was a job well done, and I suppose it helps them cope with the busyness of the job on a day-to-day basis.
recognise, I mean, that Kay's point, that care homes can deteriorate very quickly. And do you think that Michael's point, that actually if we did have some kind of way of communicating or being communicated to from staff and residents and carers of residents in between times is a good way forward?
I think it would be useful to have the, as we call it, intelligent monitoring in between time. I think there is a real challenge for CQC in terms of the different sizes of providers to be able to monitor that downward trajectory. So there's a number of ways we can do that, is by our liaison with our relationships with the local authorities, with the commissioning teams, and having that regular exchange of information so that if they're beginning to pick up a slight change, that we can keep an eye on that. But it's about using all the resources already there to see if we can pick up a pattern of deterioration. Some of the smaller providers, it can be quite difficult to get that pattern. On a larger provider, you can see, you get into, quantity of scale, so you get enough information coming in to see a trend. But sometimes the small providers can be quite difficult to pick up. But as I say, it's about using the contacts we have out there and making sure we're talking all the time.
Yes, Camilla.
So I never ever want to disagree with Michael, but I think we need to be a bit wary of doing anything that puts an extra burden on the organisation. And I think the most powerful tool for us is going to be when these kind of stories get out and people start to feel more confident and start to know how to contact CQC, because I think that this is the point. I mean, given that care does deteriorate very quickly, it's very hard to pick it up in a random sample. And what we need to get to a point where people have the confidence to think, right, actually there's something going wrong here and there's an organisation I can contact. And I think the more actions of this kind we take, probably the better that, the easier that will be.
And just to supplement that, I think that the other thing that we will be taking in consideration as we're looking at what we're doing with this is, what do we do to hold the provider to account, not just through their professional registration, but also potentially through prosecution as well, whether there's that fits with the evidence and the legal bars that we've got to reach. And I think it is, and it goes back to the point that Lewis was making right at the beginning of this conversation, is being clear with people that concerns, you don't have to accept what you think is not acceptable. We will do something about it. And sometimes that something about it is a difficult decision for all of us, including the relatives, because their concerns for their loved ones. But it is much better that we're getting in there, that we are identifying these concerns, that we're supporting our staff, and we had great support from legal and other members of the team across the organisation to make sure that we could take this action in a timely way that did protect people and made sure that those folk who have now been settled into new places, will actually have a much better quality of life than that they were experiencing before.
Thank you. Gail, thank you very much for coming. You can stay or go, entirely up to you now. But thank you. David, do you want to...
I think she's got to go and prepare a legal case, David. But anyway, picking up on a report, I'm now at paragraph 6. We had a discussion at the last meeting about our performance on safeguarding, and I advised you of an audit that had been undertaken in relation to alerts, safeguarding alerts. We've now carried out a similar audit in relation to safeguarding concerns, and the same pattern that we reported at the last meeting has worked its way through in relation to safeguarding alerts. This is an issue predominantly with, in 85% of a sample of 550 cases we looked at, of either recording or coding. So what we're doing is we are addressing those issues in relation to both the recording and the coding of that information. So the action that I advised at the last meeting that we were taking in relation to establishing a new safeguarding committee. This isn't that we didn't have a safeguarding committee before, which was a tweeted question to the Health Select Committee yesterday. We did have a select committee, a safeguarding committee. We stood that down and we've started again. We've re-energised it, and that committee met for the first time on the 18th of November, and at the bottom of the paragraph 6, we've laid out the work programme that they've set in place in relation to overseeing the audit activity and then looking at the systems and processes that we have in place to take this forward. We'll continue to report to the board, both through our performance reports in relation to our performance on this, but also in terms of giving you an update as this work progresses through the organisation, and ensure that you're aware and able to challenge and scrutinise the work that we're doing in this respect. In 7, I'm just setting out for the board the work that we're undertaking in relation to special measures. There have been discussions at the board previously, David, in relation to our approach to special measures. I think pretty much the approach to the NHS and special measures is set out, and that system is now in operation, and Mike has reported on numerous occasions where special measures have been introduced in relation to trusts and the progress or otherwise that are being made for those trusts that have been placed in special measures. But on page 5 of this report, we're trying to just draw together the way that we anticipate this working in relation to primary medical services and in relation to adult social care. So we'll try this approach in the early part of 2015 and begin to shape it over the late winter and spring of next year with a view to implementing this from April of next year. We are in discussions with adult social care leaders and with primary medical services leaders, and those conversations are ongoing and are not concluded. But effectively, the 2 bullet points on page 5 for NHS Trust, where Mike makes a recommendation that the trust is placed in special measures when an NHS trust or foundation trust is rated inadequate in well led and inadequate in one or more of the key questions, and special measures will normally last for 12 months. In adult social care and primary medical services, for providers receiving an inadequate rating at a population group or key questions, then they're re-inspected within 6 months. And that's a final warning that if no improvement is made within 6 months, they'll be placed into special measures. They've got a further period of time, 6 months, in relation to demonstrating that they can come out of special measures. The impact of this at its simplest is it's an 18-month period in relation to adult social care and primary medical services, and 12 months for acute trusts. The rest of that paragraph goes on in relation to these thresholds or criteria by which special measures will be introduced. One of the reasons for this is the judgments in relation to inadequate across a 40-box grid in relation to NHS. What is it? A 55-box grid in relation to mental health, but it's a 1/5 for adult social care. It's lesser again in relation to primary medical services. So we need to make sure that this is a proportionate response and sufficient time is given for those organisations to begin to approve. And of course, the bottom line, as is in the final bullet point in relation to those paragraphs, is that the final re-inspection is really to determine whether there needs to be a cancellation of registration. So this is the debate we had about special measures, is there's now an end to the process of regulation and the process of improvement. This can't, I think this was implicit in your question, Michael, about a report in 2009, and in 2014 there's a decision made in relation to poor quality care. I think what this is doing is now putting timelines of timing out the length of time at which something can be inadequate and how long that can continue without demonstrating improvements, and saying there is an end to this process. And I think that's the significance of this. So slightly different approaches for acute primary medical services and adult, but the principle is the same, which is at what point do we say enough is enough? There is a line beyond which we should not go any further in terms of care being inadequate and having been inadequate. This effectively is saying in PMS and adult social care you will have been inadequate continually for 18 months, and that is the line which should not be crossed. Have I got, go on. I've got this right.
No. You have, but it was just to draw the distinction between where, for example, a care home was inadequate overall, so typically 2 or more of its key questions, in which case it would go straight into special measures. Typically that would be a 12-month period. But you're absolutely right that there is also the case where they are inadequate in, let's say, the safety domain, but not inadequate in the other questions. In the way that we aggregate our ratings, that would make them requires improvement overall, but we still don't want that to be a question where you can just continue to lapse of staying inadequate on one area. So we give a last warning of 6 months, which I think was what you're adding to the 12 months. So it's absolutely right, the total can be 18 months. But just to clarify that difference.
This is very, very helpful. Could you just tell me a little bit about what special measures would mean for a general practitioner? I understand the timescale, but obviously I imagine the same sorts of things aren't going to be happening in a GP practice in Stow-on-the-Wold as they might in a big teaching hospital. So what actually do we expect to happen once we announce somewhere is in special measures?
Yeah, so that's absolutely right. With for an NHS trust, a foundation trust, there is an agreed support from the TDA or monitor alongside the action that we're taking. That distinguishes between our role in calling the problem and the monitor or TDA's role in supporting the leadership in putting it right. Because there isn't that improvement, statutory improvement body or bodies in the other sectors, whether it's primary medical services or independent healthcare or adult social care, that formalised regime can't exist. But there is conversation going on between NHS England as to whether they can provide matched funding in some cases with the individual practice. And I know there are arrangements being looked to be put in place with, I believe it's the Royal College of GPs, but it's important that that is not our role in it, and it is for the commissioners to decide whether that's appropriate in that in individual cases to provide that support. But there is a desire clearly to provide support to GPs that have got themselves into that position. It just clearly doesn't come from us, and it's not on a statutory basis.
Would I be right in thinking that's a gap which is, in terms of its distance, has increased since the abolition of primary care trusts?
No, I'm not sure that's right, Rob. I think the same premise that a commissioner doesn't have the same role as a monitor or a TDA in directly supporting providers has always held, whether it's CCGs or NHS England or primary care trusts.
It's simply the primary care trust used to, and now NHS England has the power to deregister, if you like, people, general practitioners from the performers list, do they not? And that's a sort of similar regime to what Monitor might have over a foundation trust. It's not commissioning, but I'm sorry, it's not. It is a bit of a regulatory role that's there, but my sense is that that is not as present as it used to be.
I'm outside my knowledge exactly the changes that have happened in terms of ability of the commissioner to take action. Clearly, it has switched from being primary care trust to NHS England in the case of primary medical services. But I think the real change here is a regulator who's willing to have a special measures regime. Fundamentally, the issue of how a commissioner deals with that would have been present under the PCT rules, just as it's present under the NHS England commissioning of GP services.
I think it had a different edge to it, I think, Robert. I think the bias was much more about ensuring people were good to do the job that they've been asked to do from the PCT, and was much more of a supportive role. As much, I think the focus was much more about education than that harder kind of regulatory edge of saying, actually, there is a line beyond which this should not go. I think what it flags is in part the conversation that was taking place last night about where is the improvement capacity across the health and care system. And I think a lot of the improvement capacity that has existed in relation to acute hospitals. I'd personally argue it's not been the same in relation to mental health. I don't think it's existed in primary medical services. And beyond what organisations like Skills for Care do in relation to adult social care, I think it's virtually non-existent in adult social care. So I think the challenge moving forward for the system, if such a thing exists, going back to last night's conversation, is where is that improvement capability and capacity going to come from right across the system? For those organisations that those services that need some help to actually fulfil their potential, where do they go to get that help? And for those that are private businesses, where do they go to get that help? Is that something that the state should reach into, or is that something that they should be sourcing within their own resources? So there are, I think, some really important conversations. I think that's one of the biggest gaps we've got at the minute. Jennifer's spoken a lot on this. But I think we do have an agreed definition of quality now, and I worry people keep reopening a definition of quality. I think we just need to say we've got that definition of quality, and what we need to do now is push for a greater agreement about what's the improvement capability that exists across health and care.
The only point I'd make out of that is, as a question really, is that if there is a perceived absence or of the same level of support available in the system, we as regulators, it might be thought, need to exercise a greater degree of scrutiny, because if we know that the support's not there, then we know, do we not, that there's a greater risk in terms of the patient.
Another aspect of that is that we potentially get sort of accusations that we're being too hard. It's kind of not fair on some services because they haven't got the sort of access to help and support to improve. And I don't think that we should stop, but that is the other kind of side of it, really. And people, we kind of add to the sort of pressure and the low morale. And I don't for one moment think that we should, soften our approach, as it were. But it is something that's an issue for us. Yeah.
Okay, thank you. David, carry on, Ian.
So, in paragraphs 8, 9 and 10, there are updates from Mike and Andrea, and an update on behalf of Steve, which is, I think, the common thing through all three of these paragraphs is just an update in relation to the number of new inspections which are being rolled out. Andrea's identifying here that there have been over 1,000 new inspections since October of the new methodology. We published yesterday the advice to providers in relation to overt and covert surveillance, and the work is nearing completion in relation to the final draft of the leaflet that will go to the public, with some further work being done in relation to plain English campaign application to the leaflets. Interesting piece of work, I think, in Derby by Mike and Steve's directorates in relation to speaking to hard-to-reach groups, not specifically linked to a particular inspection, but to inform a number of inspections which are going to take place, again reaching for different ways of actually undertaking some of our new methodology and learning from that as we go. And I think that, again, leans into some of the things we may well do in the future. If I can go on to intelligent monitoring, David, in paragraph 11, we've got a further debate later with the board on this, and perhaps it may be that's where a fuller discussion might take place on GP intelligent monitoring. But what we've done in this paragraph is set out at a very high level the timeline and the beginning of the explanation of what happened in relation to GP intelligent monitoring publication, and particularly the issue about the indicator around access to general practice, which was wrong, which led us to withdraw that indicator, but have to change the bandings for a significant number of general practices. And the difficulties that caused to those practices. We have apologised directly and in person to those practices that were most affected, and that was done by either a specialist GP advisor or one of our senior colleagues in primary medical services. We've commissioned a lessons learnt review of the team that were involved in this work, going through the beginning of the work from January of this year through to the publication and the republication last week. But we've also commissioned our internal audit service to carry out a review, not just of what happened in GP intelligent monitoring, but of all the systems we've got where we publish any report which has data in it, to make sure that any learning which has come from this particular issue can be extended to our other publications. I know the board have had a fuller explanation in writing from both myself and from Paul in relation to this, and as I say, there's an opportunity later during our time together today to actually spend some time going through this in more detail. Should I pause at that point, David?
Yeah, just to add that we will have this. When we've been through it in detail at Michael's committee, it will come back to the board in public fully in January. So it's not that we don't want to have the discussion in public. It's just that we want to have all the detail before we do. But if anyone's got any questions they'd like to put to David or me now, that's fine. No? Okay.
I think there was a slight danger of not appearing to talk about it at all, since it was quite a big incident. I mean, I think it's good to have a proper review and all that. I mean, I suppose I was struck by, first of all, perhaps the obvious point that there were, that for some people, it seemed like this was this brought out a reluctance to accept public scrutiny of their service, and that I was surprised by the strength of feeling that was still there. It felt to me like people hadn't picked up the message of Mid Staffordshire about the importance of external scrutiny of what we do on behalf of the public using public money. But the second thing was I felt very strongly that there are a lot of that to some extent that hostility strikes a chord with quite a lot of clinicians and people in clinical services because of the general sense that they're under pressure at the moment, and we just need to make sure that we don't look like we are adding to an unfair pressure on their practice. That seemed to me to be one of the main messages that will come out of this. There are lots of people who are good clinicians, good doctors, good nurses, who are in the front line who feel that that because of resources and rising demand and because of sometimes public attacks, sometimes political comment, that they are being treated unfairly in the system, and we are in danger of getting caught up in that. And this was, I think, this incident. Which was actually about indicators and a technical issue of indicators, played to that sense among a lot of clinicians, which is very real for people. And the message for us, I think, whatever we discover about our indicators, and that needs to be a more detailed discussion, maybe at a later date, we just need to make sure we pick up that bit of the message, that there are a lot of people who are worried that our role is a slightly punitive, critical role, when in fact none of us, I think, is here for that purpose. I think this is to misread what we are intending to, what we're here for, and that message that you can be on the side of the public and the patient, which obviously is what CQC is primarily about, but at the same time on the side, so to speak, of the good clinician doing their best in difficult circumstances, and we've just got to make sure that message comes across. And it looked to me as if it isn't despite many of our best efforts, it isn't entirely coming across. And the way that we talk in the future about the banding, for example, Paul, you and I have had an exchange of emails about this, which I found very helpful, actually. You know, just being modest about what the banding means. We need a way of deciding the priority for inspection. That's its prime purpose, and we need to be clear that in the way that we talk about it, avoiding language of risk and concern, but talking instead about priority for inspection, that we get we position the message correctly and fairly for people who are otherwise feel that we're another source of difficulty for them. So getting the banding right, getting the wording right, and getting the overall messaging right about what our role is in relation to the good practice and the good clinician, I think that to me will be the long-lasting legacy of this incident.
Yeah, I think we need to acknowledge that we have not been very good at telling this story, and we have not always explained to people very clearly the difference between banding and risk. And I think it's, you know, because we're all involved in the technical discussions, we don't necessarily remember that people on the outside, whether they're clinicians or the public, are confusing the two things, and they're thinking if somebody's in one band or another, that directly says something about risk and patient safety. So I think I agree with that. I think we need to be a bit cleverer about the way we tell this story. But the other point I wanted to make was David, on you said just now we had an agreed definition of quality. I had a really useful meeting with Paul Bate last night. We sat down and went through all 37 indicators because I just sort of felt that I have raised concerns before here about whether those are the right ones. And I think people are raising legitimate concerns about the measurements that we are using. We are very limited in the data that we have. Clearly, we haven't always explained to people that we're using that data to focus our inspections. The data in itself, you know, is just part of the picture. But I do think there are legitimate concerns being raised, and I think it would be useful for us, well, I don't know if we do acknowledge that this is we're kind of on a journey, and I'm not sure I agree with you that there is in primary medical care whether we have a final agreed definition of quality, because I think we're still, you know, we're at a much earlier stage, it seems to me. You know, we're only actually looking at 3 domains rather than 5. You know, I just think, you know what I mean, David? I think maybe we need to, I don't know, I think we're just clearly at a slightly earlier stage on the journey towards getting the definition of quality that we all want, but for various reasons, one being, in my view, that we can't assess individual GPs and we can only assess practices. We're not, you know, we're not at the end of the journey on that.
If I've conversated with a number of board members in the wake of what's happened and over a decent period of time actually on intelligent monitoring. They've been genuinely helpful, and thank you. I think that point that Lewis makes about the importance of not being seen to be putting clinicians at all in opposition to being on the side of patients. Quite clear that's a clinician and all people working in care services, so primary, you know, calling and duty. And to link the 2 points together on that, you're absolutely right. Our ability to transfer transparently the message that we want to put across through the media without interpretation isn't one that we've quite got right yet, nor any other body, it's worth saying. But on the day, for example, that we were publishing intelligent monitoring in November, was also, fortunately, that we were able to talk about the 2 first outstanding general practices in Salford and Earlham. And also, when we were publishing intelligent monitoring, we were able to show that over half of all practices were in the lowest possible banding in terms of their priority for inspection. And I think we use the words, there's an overwhelming majority where we are not seeing concerns that we therefore need to prioritise inspection on the basis of. So we will continue to do that, but with a sort of certain, whatever the word is, humility that it is difficult, but we need to keep plugging away at the differences between data and a final judgment. But to reiterate David's point, that we did take an approach of fix the problem, apologise, and figure out how to make sure it doesn't happen again, and to reiterate that apology to the practices most affected. On your point, Camilla, about the use of data versus the quality framework. And there's just a couple of things to tease out. We had a bit of a discussion about this. I think we very much are on a journey in a relatively early stage with general practice data, and have tried to be clear that those 37 indicators that we're currently using cover only 3 of the key questions: the effectiveness question, the caring question, and the responsiveness question. And they're particularly skewed towards effectiveness. But even there, we don't think it's in any way a comprehensive judgment of effectiveness. And that's one of the other messages we're really trying to get across. Judgment and a rating come through the act of bringing together the intelligence we have before the inspection, but incredibly importantly, alongside the specialist inspection, and bringing a GP along for that, and similarly other specialists for other areas. So I think what Dave was teasing out is there is a very comprehensive assessment of overall quality across the 5 key questions that takes place once you've been through the site visit, and it's augmented by the intelligence. But the intelligence alone, you're quite right, is nowhere near good enough to tell us comprehensively what the judgment should be, and that's why we don't use it for that purpose. The only final point I was going to say is because of the stage we're at with the data, particularly in general practice, so this is a rule that we apply on all the data, we're very careful only to look at when we're talking about risk in a particular area. So, for example, prescribing rates for antibiotics, we only call it a risk or an elevated risk when we are right in the far end of that distribution, typically 2.5% to 3% of the 7,600 practices. We're very careful not to say, well, you're just a little bit south of the average, at the same time as saying, and this is a smoke detector, this is something that we would therefore want to explore in inspection. We're trying to take that particularly conservative view so that we're not getting into the realm of suggesting that anybody that's below, in the bottom 50% is something our cause for concern is not. This is typically the bottom 2 or 3% on a particular indicator that we therefore want to ask more questions about.
Just 2 points really for analogy between GPs and the hospital state of affairs on intelligent monitoring. It is worth remembering that a year ago there was considerable anxiety in the hospital sector about intelligent monitoring when we first came out with that. And just to say about that, yes, we now know that it is not a perfect tool. It is a screening tool, and we continue to find it useful in the hospital sector to prioritise where we need to go next. And generally speaking, those that are in the high-risk band for hospitals, at least, we do find are high risk now, and in due course we'll know the same for general practice. I think the other point to make about whether we have information across all our key questions, I think it's particularly good that there are questions on effectiveness, because effectiveness is the thing that we can't judge so well on site. You can't, if I go into a hospital, unless I have the data about how long hip replacements last for, which would only come from data, I really can't judge that when I'm in a hospital. I can look and see whether it might be safe, I can look and see whether they're caring, and other things. So I think that this is where the two are complementary, and board members will know that I sent round a note trying to show how inspection and intelligence are complementary for hospitals. I'm pretty sure we'll find the same is true in general practice.
I wondered if there's anything we can do extra or differently to engage with the primary care sector, because there is this sort of, hostility is often the sort of initial reaction that you get. But then when if you can actually engage with individuals, if you get beyond that, you actually see that there's a lot of shared goals, common ground, and opportunities, and it feels, well, it's frustrating, certainly for me, when you kind of get the hostility, but yet when you actually get into some of the issues, there's so much that could be done together to actually improve things for patients and GPs, and it's, I don't know. I mean, I'm not sure what I can suggest, but it just feels that we need to do some sort of build some bridges, or maybe engage in a different way to actually show that actually, together we can actually achieve more,
Robert? Just to actually put together what Ken Lewis was saying, the value of what we are doing in this field seems to me that it promotes and puts into the public and shares with everyone the information we use in order to make our judgments. The days when it is possible or indeed justifiable to keep this stuff to oneself behind closed doors and make judgments and no one else and just to expect people to trust you have gone. The purpose of putting this information out, it seems to me, is firstly to inform our partners in this, who are the people in general practice, and the patients. I don't see why we are talking about sides at all. And by putting it into the public domain, the very debate that we're now having is being facilitated in a way that when these things were kept secret, they were not. So all those affected by this have their opportunity, not only, I hope, by lobbing bricks at us through the public media, but also through conversations, workshops, or whatever else that happens, to produce and continuously improve what we do and what they do. If I may say so, the main reason I was attracted to joining this board was our commitment to openness and transparency in this regard. And I do hope that this episode doesn't lead to anyone suggesting that that process should be reversed.
I just want to agree with that, and I think it's really important that the experience of having got something wrong doesn't cause us to retract our kind of fundamental position, because the reality is, well, they would say that, wouldn't they? I mean, the unfortunate thing about what happened is that that there were some issues found with the data which we all wish had not been found. You know, I think I can't believe there isn't a person around this table and throughout the CQC that wishes that error hadn't occurred. And the unfortunate thing about those errors is that it creates a door of opportunity for people who would complain anyway to complain with the perception of more justification. And they're right to complain about the quality question in terms of the data that we put out. But I think we absolutely need to stick with our commitment to being transparent. And Camilla's right that one can always do better at the communication, and that goes for not just communication with professionals, but actually also, very, very importantly, when we're putting information like this out into a public domain, communication with the public, who are alarmed and concerned when they hear or look at, read things about their GP practice or their hospital or their local care home or whatever it is. So communication is another area where I'm quite sure we could do better. But I don't think we should in any way consider retrenching or stepping back from the general position that we've adopted in the way that we're doing this.
I think the main way from here on in we'll communicate with GPs is by inspecting them. There will be, if there's been 700 so far, there'll be several thousand this time next year. And they'll have an experience of that being done fairly. There'll be some anxieties about that, but actually coming to the end of that inspection period for a GP is very different from being at the beginning of it, because it's the first time this has ever happened to them. And the level of anxiety before that is going to be enormous. The level of anxiety at the end of it, for nearly all of them, will be a lot lower. And so in a sense, communication through work is what's going to be the main way in which this will change.
I was just taking the discussion a little different track. One of the reasons that GPs might be upset about the information is that the information kind of gets out there. We publish the information, and people, the public, press, etc., might draw inferences from that information. But the GPs, have the GPs had an opportunity to respond to where they might be being apparently criticised through these indicators being wrong? When we do an inspection, we produce a report, we discuss the report with the hospital or discuss the report with the care home, I think, before we issue them. So there's a kind of a right of reply, if you like, for them to actually comment on what we are saying, and if we've got something wrong, to put that right, or if we've got if there's a valid point, to put that into the report in some way. Whereas with this, I'm not sure whether GPs have had that opportunity to actually put their point of view out. So I'm just wondering,
I don't mean the GP fraternity in the sense of anti-inspection, but in terms of their particular GP practice, why is that indicator higher than it might be expected to be? Is there have we given them that opportunity to actually add that to our reports which have gone, that have gone out for each practice?
Yeah, so in the build-up to the publication, the data was shared with 2 sets of 200 GPs as part of the Quality Assurance. That was one step of people being able to say whether things looked concerning in the data or indeed with the indicators. Following that, we've absolutely been receiving comments, lots of the sort of more general comments, but also from specific general practices, from LMCs on specific points of the data, all of which we listen to, all of which we respond to. Because it is explicitly not a judgment, but it's explicitly us putting into the public domain, as Robert says, the information that we use to inform our inspection process. We don't have the same level of reply and factual accuracy checking and formal appeal, if you like, in the way that we do for our judgments and our enforcement. But that's also a question of resources. But what we make sure we do is respond to all of the concerns that are individually raised, and then make sure that if a point is raised about, for example, a practice being in particular circumstances and therefore having an extreme piece of data against one indicator, that can then be taken into the inspection as part of the data pack to inform our inspectors so that they can follow up appropriately or not need to pursue that line of inquiry.
I think that if we could find some way so that the practices were able to publish what their responses were to the individual facts, to give context, so that if somebody is, if I go and look at my local GP surgery and I find that there's an indicator there or indicators which are elevated risk, and there's some raises some concern in me, that I can also see where the GP practice has responded to that to explain why that particular indicator happens to be high in their case, which will get somewhere around the process of them feeling they've been dumped on, and there's something out there which will raise concerns and a way of them responding. Now, there may be other ways of them responding, but I'm just wondering if we've thought through that process with GPs and whether there is some way of actually trying to put the two things together.
Can we leave that with you, Paul? Okay. We're going to come back and have a longer discussion about this in terms of data quality as well, and how we get assurance the data's right in January. So thanks very much, David.
So just to finish this section off quickly, David, we have had letters from the BMA and the RGCP, and we will set up meetings to begin exactly those conversations. How can this be improved and developed? And Paul and hopefully Steve will be back by then, can join me in those conversations, and we'll open up that dialogue that I think was there, but in the context I think that Lewis and Robert laid out, which is the explanation that I gave at the Health Select Committee yesterday when David and myself were asked this question in relation to this is at its heart an issue about transparency and the importance of transparency. David's asked me to do this quickly, so we both went to the Health Select Committee yesterday. We got asked questions about our fitness for purpose, the development of our methodologies. We were asked questions around GP intelligent monitoring, no surprises, and we'll send a note round in relation to the detail of that rather than try and cover this now. I know a number of people spent some time looking at it and have picked up some of the messages that came out of that. Last two updates, I'm flagging that there is to be an independent investigation of Gosport, which is covering the period of care of older people between 1988 to 2000. It's to be chaired by Bishop James Jones, who chaired the Hillsborough Inquiry, and a number of the panel that was on the Hillsborough Inquiry is going to accompany him in this panel. And it really is looking at the quality of care that were delivered to older people around that time. And Why am I raising this? I'm raising this because our predecessor organisations would all have inspected these services. Some of those records will have been maintained. Some of them will not have been maintained because they'll be time expired and they'll have been destroyed. But nevertheless, we will be asked to make a contribution to this investigation, and that contribution will largely be about accessing historical records. One cannot underestimate the amount of time that will be required going through archives, sourcing records, etc., etc. So there's, we'll have to resource this to be done properly. This is our information team that sit with Eileen and in legal services that will need to do this, and they're expected to complete their work by 2017. So an important piece of work, I suspect. And then Hard Truths, which is 1 year on from Robert, your report. The government are going to be producing their response. We've had to inform that, and many of the issues we've talked about here, which is about our progress in relation to inspection, development of inspection methodologies, etc., etc. But that completes the report, David.
Anything on the Hard Truths report? Anything? When's it going to come out?
I await it with as much interest as everybody else.
Right. Okay. Thanks, David. Eileen.
Thank you, David. At the last meeting, I think a couple of members suggested it would be a good idea to just draw together some of the terms of reference of various of our subcommittees of the board and of the executive team, and really that is what is brought forward today. Represents a bringing together of some terms of reference. It's also heavily caveated that we are working through almost all of these with a view to making revisions, ensuring that committees in the case of ACGC and RGVC can complement each other and minimise any scope for overlap, and that essentially we're focusing on the right things. We've discussed also changing the way in which REMCO operates to have a far greater emphasis on talent management, succession planning, some of the issues that we've talked about here. And it also sets out one of the subcommittees of our own ET, which is in the investment committee, the way that we actually take a view on how we're spending quite a lot of our money, and where challenge takes place on whether these investments represent value for money for the organisation. And that was revised earlier this year, but as we are a fairly dynamic organisation, even that requires one or two small amendments now. So having Sandy with us as board secretary, she'll be able to pick up some of the scope of actually marshalling and corralling us into getting our terms of reference into good shape in the new year. But to reassure you, that work has already begun. So happy to take questions, but really it was to ensure that you had them in front of you.
Yeah, thanks. I mean, the Regulatory Governance and Values Committee, it's quite new. And I suppose we're still kind of thinking about, you know, how we do the job and what should be considered at it. But I was just thinking that of kind of two big issues, which are obviously very important to me, but I think they're also important generally, which is around, I'll call it user involvement, where we, you know, how we engage with people who use services and carers. And we've actually got a statutory duty around that. And the other issue was around equalities and human rights. And again, as an organisation, we've got some obligations around that. So I wanted to suggest that we could actually build in some sort of board-level governance if these two aspects were included in the, you know, the responsibilities of the RG and V committee. I think it would be appreciated by our stakeholders, but I think they're also really important issues. And I'm kind of conscious that, as yet, that they haven't really come to the board in a kind of strategic way as yet. And I just think that if it was part of the RG and VC's responsibility, it would give it an extra sort of visibility, extra importance, and put some sort of governance around it.
I think really good points, Kay, and Paul and I and other colleagues are actually looking with Michael at drawing together new terms of reference for RGVC, so we'll certainly include those. So no, to make clear, these remain works in progress. These set out a good beginning for a new committee, but actually, as we've learned, we know that we need to do some work on them, so they do represent things which are under scrutiny at the moment.
Willem?
I had understood that the investment committee was going to be a subcommittee of the AGVC. I just don't know whether it's appropriate for the investment committee to have no non-executive directors on it. Because I thought when we discussed this before, we'd thought that might be part of the AGVC role. Because obviously the AGVC role at the moment is looking largely at the accounting policies and sort of the overall financial controls. I suppose the issue is that whenever a large contract comes to the board for approval, as it does eventually, I thought we were going to have a situation where we on the board would feel assured that there had been obviously there's a proper process, but that there was a process in looking at that, assessing that contract that had involved some non-executive directors. I mean, otherwise I feel that we are all beholden as non-executive directors to look ourselves at every contract in some detail, because otherwise I don't quite know how we're providing that independent scrutiny of contracts. Do you see something?
I wasn't around when that conversation happened. I suppose what I would say is that it would be very unusual for a committee, an audit and corporate governance committee, to have a subcommittee, if you like, or to look at the details of investment proposals. We did so at the last one because I think the board meeting looked at and asked us to take a look, so we did look at some of the assurance processes around that. I think it is more likely that it's going to be part of an executive decision process, and that the executive decision is then brought to the board, and that the board then looks at it as a whole on the major contracts, and that the papers that the board gets need to be sufficient to enable board members to make to feel comfortable with what is being proposed, or to ask questions about that. So I suspect it may be something around making sure that the papers are framed in a way which is user-friendly for non-executive members and answers the likely questions which are going to come up in that respect. And so maybe that's something we should take elsewhere and see whether we can come up with something which is a little bit more normal. And that would be normal for most, certainly commercial boards and arm's length body boards, I think, to have that sort of process.
I think that's very helpful. I think, because at the moment I don't feel that is the level of detail we're getting. And I also think it might be helpful then to have some sort of advance. We just have to try and build in a bit of advance warning so that we have proper time to scrutinise them.
Is this a good opportunity, and I should have done this earlier, to say that last week Eileen, Paul and myself interviewed candidates for the Director of Finance post. This is a post that we've created, which I think the ambition is to strengthen this area. Camilla, I think Paul's proposition about how we think this should work, which I think picks up on the challenge that you've made now over a number of different meetings about how you can be reassured that the proper attention and scrutiny is being given to this within the delegations, that executive function. And what we can do is, the appointment was Kate Harrison, who currently works with us, a qualified accountant. We've combined two roles into one in this role. We interviewed a good field on Friday afternoon and made that appointment a competitive, externally advertised role, and Kate has succeeded in doing that. I know she's keen to get into this, and we'll make sure that there's a conversation that involves Kate, Paul, Eileen and myself that actually looks about how we can ensure we get that proper reporting through, and then you feel you've given it the scrutiny that it deserves. And we can make that operate in a way that helps us get the business done without creating log jams and blockages, but gets the appropriate scrutiny in place as well.
I think what lies behind, sort of Camilla's concern, which I sort of share, is that our interest as a board is really on our regulatory things that we do. It's on the impact on care and externally, and we don't have that level of time and that we really focus on the internal things. And so actually, I just know that when we come to how we spend time at this board meeting, we'll spend much more time on GP indicators than we will on scrutinising, quite a big contract. That's why I think we've, as a board here, we'd like to feel that more work had gone into that scrutiny of those projects before it comes here, because we don't allocate enough time or importance of doing in this forum. I think that's sort of, does that lie behind? That's sort of my feeling, at any rate.
Yeah, I mean, I don't think that means that we couldn't put more time into it as a board. I think we need to. We just need to put more time into it at some level. It's only a question of, as Paul says, how we do that and where we do that. But we do have a duty to taxpayers as well.
Yeah, we do.
And we have to fulfil that duty, and I just want to know that we are doing that.
Yeah.
Sorry, on exactly that point, because that's my fear. I mean, so we could have a great paper, but our tendency is to think that, as the agendas are planned, is that these things are come at the end of a packed and fascinating agenda, and there's a kind of sense that one feels there's a roller coaster you can't get off, and you've got to just kind of tick it up, which is not the way that we should be making decisions of that sort. So I think there's a real decision which perhaps lies with you, David, which is do we actually want to make the space to fulfil those responsibilities in relation to the big procurement contracts at the board? And if not, do we need some kind of occasional finance and general purposes committee or group of non-execs who we ask to do that on our behalf? So when it does come to us, we've got some non-exec assurance as well as some exec assurance about the decisions that we need to make. But one way or another, a group of people, which includes some non-execs, needs to spend the time to look at those issues, I think. And that's the bit for me that when you read the investment committee at terms of reference and see the way that works and reports into ET, and then think about what we actually get at the moment, that's the bit that's missing for me.
I think Paul is saying you feel the structure here is about right, but we just got a bit more time at this board to do it. So I think that's what we'll do. Unless you have second thoughts about that, Paul, outside this meeting, I think that's what we should do. Make more time at this meeting to give it proper scrutiny. Yeah.
Yes, sorry, personally, I think that's right. That this board does need to do this at this meeting rather than to do it in subgroups and make sure that allocate particular non-execs. I'm not sure that's the right thing to necessarily do. We can take it away there and look and see if there's something else.
I'm not recommending it. I'm just saying the reality is that, I mean, it's to David's point, the reality is that we don't then give it time, and if we are not going to delegate it, we need to give it proper time.
Absolutely.
Could I just, so I think that's really helpful. I think what we're finding, and as a board developing, is we get now much better quarterly performance reporting across all of our activities. And I think what we want to do is to refine that still further so that we get at that quarterly basis a procurement report and we get a finance report, and we want those to have a greater level of emphasis. I think there's a real desire from the people who work in those areas to see an amplification of that, so I think they'll welcome what you're talking about. We also, to assure you, on contracts of more than £1 million in value, not only that they come here, but they also in process terms go to ACGC for reporting as well. So very large contracts have 2 points of contact. And I think we have increased the level of scrutiny as an ET of the way that we spend money. And I think we all recognise the importance of doing that. So it's those levels of assurances, I would say, and the desire for the board to see more and to be more involved is shared by all of us.
Okay, thank you, Eileen. Next paper's yours. Rebecca.
Thank you. Yes, and what you have is a revised conflicts of interest policy for board members, which has been updated to align with the new staff policy that you've already seen. So it's consistent with the staff policy. It's been updated do small things like reflect Sandy's new role, and it's clearer than the existing policy about what needs to be in the declaration annually, what the definitions are of what we expect to be declared, because some of the existing definitions are a bit opaque, and it's a bit more instructive around how the board will actually manage interests which are declared and manageable. So it's designed to be more helpful. It's got clearer, more modern English, and it's been approved, well, commented on, and in the same way as the staff policy by our internal audit group. So I hope it's clear. If you're happy with it, I did spot a rogue square bracket, and we need to include the cross-reference to the standing orders.
Just one thing, the definition of relevant person is hugely wide. I mean, I don't know what my niece's partner does. I mean, it just seems to be, how practical is this relevant person definition? I mean, if it's standard, it's a point that Paul Rue raised with me last night as well. I can't really be expected to ask all my nieces and nephews and their partners what they're doing at it.
Yes. Depending where they are, yes. We could include some words to sort of reflect, you know, if they're actually proximate to you. I suppose families are all different, aren't they? So some people will know and some won't. I don't think you're expected to go out and make assiduous inquiries.
It's just worth pointing out that if you don't know that they've got an interest in something, it's unlikely to be a conflict.
Yes.
You know.
That you've got to make reasonable steps to find out. I mean, it's probably an academic, this, but...
I don't think it is just academic. I think it is a very practical thing that we need to do here to actually work out what is reasonable in these contexts. So I think that actually providing some guidance on those key aspects, perhaps in the form of examples, might be a good thing. And I know that when we've done the staff conflicts of interest paper, there were some examples of what constituted conflicts of interest to try and help staff with making those decisions. So I would suggest that maybe looking at some guidance to help board members with understanding how far they need to go on this and what are the most important aspects for them to look at. I think would be helpful. And I'd be happy to kind of take this away and do a little bit of crafting with Rebecca to see if we can come up with something that.
Yeah, I think that's a good idea. I think it will fall to Sandy and I to actually take forward the implementation of it, and yes, that needs a sort of common sense application and some. More. The
reason I say this is that I've been used to years and years of this within an audit firm, and it is where it's very onerous, and this appears to be considerably more onerous than that was. Now there are differences between an audit firm and this, and I think we need to make sure we draw those out, and that actually the most important thing is the principles behind it, and the reasonableness of how far you need to go around it. And I think we can do that quite easily if we have a separate session on it.
That's very helpful. Thank you very much, Paul. Will you pick that up afterwards?
Yeah, absolutely. That's fine. Okay. I think if we're happy with the principle of it, what Sandy and I will do, we'll go through the definition of relevant person. We'll talk about what guidance we can put together and circulate that round.
David, sorry, forgive me, because I'm not sure whether I should be reading this into something that's in the list, Rebecca, and apologies that I didn't kind of raise this before, but obviously it wouldn't be us as me as an executive member, but I might have somebody who falls into the relevant person who works for an organisation that we are regulating, and whether that should be included in the list. And I'm not quite seeing that it is, because we've said if they're going to contract with us, absolutely get that. The bit about holding a position of authority in charity or voluntary organisation kind of got that, but there isn't anything about that. My husband might at some stage work for an organisation that Mike is inspecting, and you'd kind of probably want to make sure that we were aware of that. I couldn't work out how it was.
Can you pick that up outside?
If it was halfway down, but I'll pick it up outside.
Yeah, it clearly needs to be. Okay. Michael?
No, just a quick point. I'm not sure we're agreeing to the principles of this means because, there's problems with, a great deal of this. I don't know what actually, in terms of conflicts, has an interest in the outcome of a matter that is distinct from the CQC's interests. Why on earth should that be, I would have thought by definition there's not a conflict of interest, so what does it actually mean? So I think this needs a sort of a serious new look, really, and hopefully Paul, will be able to help on that.
So I think we don't take another look at it, Rebecca, if we can. Okay, thanks very much. Anything on the audit committee?
I hope the note is relatively self-explanatory. I'm happy to take questions on it.
Any questions for Paul? No. The RGVC meeting? Oh.
Just quick, on the Audit and Corporate Governance Committee, which non-execs are actually sit on the committee? Because at the last meeting, obviously, Paul, you were chairing it, and then there were the two independent members, and Michael gave his apologies. Are they the only non-execs on it? It seems a bit...
Robert's.
Oh.
Robert's on it.
Oh, OK. Right. That's enough, is it? OK.
The plan is to look at our governance structure, Kay, after Christmas, now that Sandy's here, and then we'll have a look at who's on each committee, and we'll do that. Michael, anything on the RGVC you want to mention?
No, like Paul, unless colleagues have a question.
Issue, which is paragraph 42, Paul, in your report, on the Department of Health audit around failure of the social care early warning system. Does this materially change the discussion we had about market oversight in any way? Does it materially change the responsibilities we're intending to take on? Or have I just misread that? I wasn't clear what the work,
no, I don't
what
think
the extra work was going to consist of.
Well, as I say, it says here that the PF, there's discussion going on with Sally Warren at the moment to find out whether there is something that falls into that. I'm not sure what the answer is on that.
Okay, so it's not a sort of. It was hard to tell whether it was a major or minor issue. Do you know what I mean?
I don't think it's a major issue.
No,
it wasn't raised as a major issue.
I think I can give you that reassurance that it's not a major issue. No.
The issue is, I think the issue was about the transfer of the function, which is currently held in DH, to us. And the risk is, if we don't have the people in place to take the work, how that risk will be managed. DH have agreed to extend the contract they've got with BDO, who are which is the means by which they currently carry out the oversight for the 5 largest providers, and they'll continue to run that contract to July, I think it is. So that's a mitigation for any risks that if the people aren't quite in place when the 1st of April comes, that work will not be stopped in effect. I think the conversation we had at the board, you actually saw what the timeline was to get the recruitments in place. It's very tight, but currently that's what we're planning to do, and I know that Sally and Andrea are working very hard to make sure that that happens.
Thank you. Anything on the NIGC, Paul?
For taking it in the same spirit, to assume people have read the paper, but I would just like to say thank you to John Carvell for raising the issue around the expectations on advice being given and provided by the committee, and also to Alan Gillies for his work on the outcome measures for the committee, and to remind the board that the legislation says this committee needs to be in place until March 2015. So we shall need to take a decision beyond that as to what approach we take to getting advice within CQC on information governance.
Thank you, Paul. Any comments on the forward plan? Any other business? Any questions from the floor? David?
Well, first of all,
There's a microphone just coming.
First of all, I'd like to congratulate you on actually closing a care home, and I must say I think this will send an extremely valuable message to every other care home owner in the country, because I think people tended to believe in the past that the CQC would never actually do it. Now I've done it. My one question is this, which I have asked before, but I didn't get an answer, is why is it that you seem to have set your face against using covered staff in care homes, as Panorama did so successfully in the Old Deanery, and I think also in Winterbourne View? I think you might have got to the truth in Merrick Court a little bit quicker if you'd had that sort of thing.
2 points in response, David. Thank you. We do close care homes. This is not the first time that we've closed a care home. It's not the first time we've closed a care home this year, and it's not the last time we're going to close a care home this year, as we've closed another one this week, and we're seriously considering another situation at the moment. But I think you're right, as being clear about what we're doing and how we're doing it does indeed give a message to care providers that there are standards that we're expecting people to meet and that we will not tolerate, and we will take action when we are seriously concerned about the health and well-being of people using those services. With regards to using covert staff in services, I think that we did not need to use covert staff in this service. We had the concerns raised with us by Surrey County Council from the safeguarding issues that they were seeing. We went in, we absolutely observed it for ourselves. People, either were not trained, there weren't enough of them, or they didn't know that they were doing the wrong thing. They absolutely did not. We didn't. They were doing things in front of us, in front of the inspectors, which you would not have thought that anybody could have done and thought was reasonable to do anyway, but certainly not in front of an inspector who has the power to close you down. But actually, that is what was happening. So I think that it is something that we have the potential powers to use, but I'd much prefer that we worked on the basis that we responded to the concerns that people raised as we did, and we respond quickly as we did, and that we take the action that we did.
Thank you, Chairman. Question, excuse me, one question today relates to the Parliamentary Ombudsman and their reports into NHS services, hospitals in particular. How does CQC take into account the Parliamentary Ombudsman's report, particularly when they are severely critical of particular services, as was the case with West Herts Hospital Trust? Does this facilitate further action from CQC?
Whenever we receive a report from PHSO or from other directions, that comes into us, it forms part of the intelligence that we then have about an organisation. We will then take a decision. Does that require immediate action in terms of responsive inspection, or should we be taking that into account when we are next inspecting anyway? And so we will always have that information to hand, and I would anticipate in that case that we would follow up on that during an inspection. And obviously in some of these cases the incident may have been some time ago, but we would then want to know what measures the Trust has taken since then to ensure that things like that don't happen again.
Bran.
A couple of points, really. One is just an observation in terms of the board papers and some of the language around the board today. There's a lot of acronyms in that, really, and I just think that we all fall into that. But I think for members of the public might be viewing this and might not have seen the papers, so there's an opportunity for that, really. So that's just a constructive comment. The bit about the GP and that banding, really. I mean, someone said to me, we do fall over because that's what makes us human. But we get up and we're stronger from doing that, and provided we don't repeat the same mistakes again or whatever, really. So I think there's an opportunity to be stronger from this, if I'm absolutely honest. One point I was absolutely told today to say was from Jan, and I know what everybody wasn't at the board meeting when that very privileged opportunity was there and whatever, really, but she wanted to say thank you and whatever, really. And she asked me, was I right when somebody said, tell us what you're most proud of and whatever, really. And she said, I could have thought of all these nice, fluffy things to say, but it's a direct question. And actually, you know, I felt it needed a direct response and whatever, really, in terms of the way she was open and honest to say that and whatever, really. And that came across to me, as it does from the board and board members, that actually, if we are on the side of the patients and the public, we can't compromise those values. And those value-based approaches, really, will make us what we are and also give us that focus and direction for the future as well. So from Jan, thank you very much for that privileged opportunity. On the 23rd of January and whatever, really, the cavern will be opened or whatever, which will be a match for Liverpool. Duncan Selby will be joining us, and so will a member of the Care Quality Commission, to actually celebrate how a small little community group, and I call it small, is actually taking forward and will take forward as of next week a national piece of work, and some of it has been discussed around the table, and I'll share it when I can. Thank you, David, and the board.
Well, Brent, thank you very much for that. So I think it's a very good point to end our pre-Christmas board meeting on a high note. So, and congratulations to everything that you and Jan are doing. It's fantastic. So thank you all for coming to the meetings. We'll break for coffee. Thank you.